Welcome to the Peds NP, Pearls of Pediatric Evidence-Based Practice. I'm your host, as always, Dr. Becky Carson, pediatric nurse practitioner and clinical faculty member at the Duke University School of Nursing. And thank you for joining us again as we talk about the ABIM Foundation's Choosing Wisely campaign, an evidence-based endeavor meant to spark conversations between providers and patients about what tests and treatments are really necessary. More is not always better, and we should always take it back to the patho to make our decisions. So it's important to pause and consider how we're being good stewards of our healthcare resources. If you missed episode 79, all about the background of the Choosing Wisely campaign, hit pause and go back to listen to the underpinnings of why it is so important to have these conversations and how this campaign came to be. Once you're up to date on the foundation, these case studies will help you apply important concepts from your brilliant core pediatric knowledge to those tricky situations where it can be so tempting to add on the extra diagnostic tests and treatments. A Choosing Wisely gut check will support your rationale with strong evidence from the literature. It'll show you that the excess represents waste that will not change any prognostic outcomes for your patients. This series is complete with peer review from my acute care PNP colleagues using a standardized approach to quality assurance. You can learn more about the peer review process at thepednp.com/peer review. Before we get started on today's case, I want to remind you of our learning objectives for the case-based discussions in this series. Today, we're going to hear about a common presentation in primary care pediatrics, though you'll see cases like it in settings across the acute care spectrum. We're then going to apply concepts from the Choosing Wisely campaign to help guide your management and remain a good steward of resources. And because we at the Peds NP practice family-centered care, and making decisions involves caregivers too, we'll talk through the tough conversations that provide reassurance to concerned caregivers or the conservative multidisciplinary team. We don't want to be paralyzed by or complacent about concerns for the child's health. There's something tricky about these presentations, and we care deeply, so we want to do something for the child. But instead of pacifying ourselves, our colleagues, or the family by layering on extra tests and treatments that can actually be harmful to the child, this campaign and this series is about taking a beat so that we can apply our foundational knowledge to the problem and come up with an evidence-based solution that has everyone on the same page. Let's get started with our next case. An infant with diarrhea and dermatitis. The next patient to be seen is an 8-month-old male who presents with a diaper rash after a mild diarrheal illness. The infant has had about 3 to 5 episodes of non-bloody diarrhea per day for the past 3 days. There was no vomiting and no fever. There doesn't seem to be any associated abdominal pain or cramping, and the child's oral intake has been adequate, so good wet diapers. He eats solid foods about 4 to 5 times per day. In fact, he's so interested in everything on the family table that the parents just feed him off their plates. And that means they've been adding new foods to the diet at a pretty quick rate and can't really tell if there are any foods that have been problematic. The infant has a past medical history of atopic dermatitis, which you appreciate as a moderate case, most prevalent on the convex surfaces of the face, abdomen, and extremities. His cheeks and chin are a deep red, more like post-inflammatory hyperpigmentation than an angry red acute irritation. And you note patches of dry, mildly thickened, scaly plaques that match the areas where drool tends to irritate his sensitive baby skin. The parents use Vaseline on the cheeks when they remember, and they've never tried anything else. His past medical history is significant for acute otitis media at 6 months of age, for which he was treated with a 10-day course of amoxicillin. Immunizations are up to date. He attends daycare and has had no recent travel or sick contacts that have similar symptoms. Before we move on to the physical exam, we can begin to formulate our differential diagnosis, which I'm sure you were doing from the moment you started to hear the constellation of symptoms and pertinent positives and negatives. These illness scripts are like templates that you can play a mental matching game with. If you'd like some extra help with this, check out episode 69 on developing the acute care differential, or an oldie but a goodie, episode 14 on illness scripts. Top of your differential list is probably viral gastroenteritis because of the daycare attendance and his age. Fecal oral contamination with viral pathogens is very common in infants because of their hand-to-mouth behaviors. Maybe you're right. If so, this case is overall reassuring because it sounds like he's having mild symptoms and it lacks red flags that might make us think about bacterial infections or more serious illness. I would have been worried if I heard about blood in the stool, persistent vomiting, high fever, or toxic appearance. But none of that seems to be the case. And speaking of bacterial infections, some of you may be thinking about his recent antibiotic use to treat otitis media a couple of months ago. I'm glad you're thinking beyond the obvious. Put a pin in that, and we'll come back to your differential in a few minutes. With his age and voracious appetite, perhaps we could consider some food sensitivities. But that remains to be seen as the parents have not been introducing foods methodically, so that muddies the water of the trigger food. There are certainly other differentials, but I want to stick to these three for now and let our physical exam continue to guide us. Now, this physical exam is going to be tricky to fully describe because a picture is worth 1,000 words, but this is clearly a podcast. And since this is a micro-learning podcast, just do your best to imagine the findings in this exam based on my verbal descriptors. As a side note, realize that you'll also need to describe this rash in your note using English words, so it's a good practice for documentation. And here are a couple more pro tips. Remember that the physical exam describes the findings. It doesn't give any diagnosis. Be sure to describe rashes with medical terminology and descriptions of the primary and secondary lesions in a way that you could objectively follow its progression if you saw the rash again in a few days. All right, on to that physical exam. Vital signs and anthropomorphic measurements are all within normal limits, and the child is active, smiling, and playful with that crinkle paper on the exam table. The HEENT exam is unremarkable. He cleared that otitis media infection, and bilateral TMs are pearly gray with normal bony prominences and light reflexes. He's got moist mucous membranes without any pharyngeal erythema or intraoral lesions. Heart, lung, and abdominal exams are all benign, and your assessment of his clinical hydration status is that he's not dehydrated at all. Let's pause here for a moment. To assess for clinical dehydration in this age group, the ideal measurement is weight change from a recent visit, because that difference in weight represents water loss from the extracellular space in a short-term illness. And since 1 milligram is equal to 1 milliliter of water, or let's think bigger, 1 kilogram is equal to 1 liter of water, that weight change directly translates to fluid loss. You then calculate the percent weight change by dividing the difference by the original weight, and then multiply by 100 to get the percent. But what if a recent weight isn't available? And in this age group, I'd consider a recent weight within about a week. And that's common to not have it. Good news is that you can still have an objective assessment of hydration. Just look at physical exam findings that indicate the level of dehydration. Assess for the presence of a sunken fontanelle, sunken eyes, not making tears, dry mucous membranes, decreased peripheral perfusion, or poor skin turgor. And there are objective clinical dehydration scales where you then match that clinical picture to the degree of dehydration. I like to use the clinical dehydration scale and the Gorelick scale because they're both validated scales. Or you can refer to your best friend Harriet Lane for her practical references on managing fluids and dehydration. If a child is not dehydrated, that means that they are less than 3% dehydrated. So the fluid loss is negligible and regular fluid intake is all that's needed. Mild dehydration is 3 to 5%, moderate is 6 to 9, and severe dehydration is anything greater than 10%. All right, thanks for that little detour. Let's get back to our head-to-toe exam. The GU exam is where things get really interesting. His diaper rash is remarkable, this poor little buddy. You know, a confluent erythematous maculopapular rash in the gluteal fold and convex surfaces of the buttocks, groin, and inner thighs, with a few perianal erosions where the superficial skin has denuded and raw exposed tissue that appears scantily bloody in areas. The skin folds are spared, and there are small papular lesions throughout the rash, but no satellite lesions. You already heard about the eczema of the child's face and extensor surfaces, but it's worth highlighting them as they do appear flared this time around. All right, now that you've completed the physical exam, we'll circle back to our differential diagnosis. Although I've used some buzz phrases that clue you into the absence of a fungal infection, remember I said fold sparing and no satellite lesions? This conclusion can be more difficult for the observer in real life, especially if the rash appears impressive or has papules that I find confuse the clinical picture for novices. Some of you might brush this warning off, confident that this is an irritant dermatitis. But what if the history were a little bit different? Say, an ongoing diaper rash that has lasted a week. Then would you be tempted to diagnose a candida infection? Or what if the rash was really itchy, painful, and uncomfortable? Given how bad it looks, there's no doubt that some of those symptoms also exist. So, how should we manage this child? With viral acute gastroenteritis at the top of our differential, we know that rehydration and the replacement of ongoing losses is the priority treatment. So we'll start with oral rehydration therapy and emphasize the advancement of an age-appropriate diet while educating on caregiver reassessment of dehydration and return criteria. For our next steps in the care plan, let's reference the Choosing Wisely campaign's AAP list on dermatology and the list for gastroenterology, hepatology, and nutrition. We'll start with dermatology. Our patient has an underlying diagnosis of eczema, a remarkable flare on the face, trunk, and extremities, and also a dramatic diaper rash that appears excoriated and denuded, which is painful and exacerbated by the ongoing diarrhea. Should we try to kill two birds with one stone? Treat eczema and any potential fungal infection with a combination steroid and antifungal cream? The resounding answer from our list is no. Whether it be for tinea corporis, candidal infections, or diaper dermatitis, we should not use combination products. There are several reasons for this. 1, you may be unaware that steroids in these products tend to be higher potency, which can lead to systemic absorption or even thinning of the skin, atrophy, and striae. And 2, these combination products tend to be expensive and may not be covered by health insurance. Remember, part of being a good steward of resources is considering the financial implications on families and the healthcare system. So what if there is itching or severe discomfort that warrants the use of a steroid in addition to an antifungal? Okay, well, if that's the case, the answer is simple. Use separate products. Prescribe the antifungal, the nystatin, the ketoconazole, and prescribe a separate low-potency topical steroid, starting with the simplest, an over-the-counter 1% hydrocortisone. Okay, but will these treat this diaper rash? That's a good question. I would say probably not. Overarchingly, you should lean on barrier creams and ointments alone to treat diaper rashes. Typically, they're irritant rashes that result from contact with caustic diarrhea. And because I'm a busy working mom and I frankly do not play, I go straight for the 40% zinc oxide on irritant diaper rashes, which is used in products like Desitin Max Strength. I find the lower potency zinc oxides like butt paste are better for mild rashes or when I'm establishing a barrier on already happy skin. Emphasize to the caregivers that they should slop on the ointment and gently clean off only large pieces of stool during diaper changes. Remember that these creams are meant to be a barrier between the child's skin and the caustic stool. When they heavily wipe off the ointment during each diaper change, they're likely contributing to the erosion of the skin by pulling off that top layer of tissue with aggressive wiping. Babies cry when they get their diapers changed with these rashes because it hurts. So I often suggest that families stop using wipes altogether because they contain some chemical cleansers that can be irritating and cause a stinging when applied to the open wounds. There are 2 alternatives to baby wipes. 1, hold baby over the sink or bath and wash the stool off with diaper changes, pat dry, and reapply a big glob of barrier cream. Or 2, buy plain gauze at the pharmacy. It lives in the wound aisle. Put that in a Tupperware with a little bit of water and just blot off the stool very gently and reapply a big glob of barrier cream. I've seen horrific diaper rashes in children in the ICU with antibiotic-associated diarrhea that tears their skin apart. But the good news is that the skin turns over quickly, and with some good application of skin management knowledge, you will legitimately see improvement with zealous reapplication of barrier creams during gentle diaper changes. Before we move on to the diarrhea, let's finish talking about this child's eczema flare. There are some among you who might be tempted to treat this exacerbation with oral steroids, just to get the raging inflammation under control. And that's exactly why I brought it up. The evidence and the Choosing Wisely campaign tells us to avoid oral or injected systemic corticosteroids in most cases of atopic dermatitis. Why? Beyond the obvious issues with adrenal suppression, growth retardation, and long-term side effects of systemic corticosteroids, more than 90% of cases will result in a rebound flaring of symptoms as soon as you discontinue the steroids. You're actually making the eczema worse. There are very few children who can't be managed with topical therapy using topical steroids and emollients, and for those children, phototherapy or biologics are the next steps in treatment. This child would likely do great with a low-potency steroid, topical emollients, either prescribed or with some samples that we know our wonderful skincare reps loves to leave around the office, and lots of education on continued moisturizing and avoidance of triggers. All right, we're ready to consider the etiology of the diarrhea and whether there's any pertinent workup to complete. We already talked about how there were no red flags in this presentation. Remember, no bloody diarrhea, a short duration, a well-appearing child. But you're still worried about an infection. We know from the basics of pathophysiology that fecal leukocytes, also known as stool WBCs, are not going to offer us specific, actionable results. Wait, so you're telling me that there's a test that does not give us helpful information? Yes. Elevated fecal leukocytes are simply an indication of infection, but their absence does not exclude infection, and an elevated level does not predict what pathogen could be causing the infection. So you're better off sending stool pathogens. In this case, since the child is not severely ill, has no bloody stool, and the duration has been less than 7 days, I'd argue that we don't need to send stool pathogens either. No testing today? What about Clostridium difficile? You promised we would circle back on this topic. Yes, thank you for reminding me. Let's talk about the patho and epidemiology of C. diff for a minute. Normal flora serves as a protective barrier against invasive colonization with C. difficile, which becomes disrupted when antibiotics universally erode the landscape and create a space of opportunistic colonization. Infants are colonized with C. difficile at very high rates, somewhere between 30 and 70%, often from maternal transfer or through interaction with their healthcare environment. But typically, they don't show any disease through an unknown protective mechanism. So that means that if you send C. difficile testing, there's a 30 to 70% chance that you'll be right, though it wasn't the actual etiology of the child's symptoms. And you're then going to subject the child to even more antibiotics and unnecessary treatments that do not actually address the underlying disorder. I'm not saying to never send C. difficile, but I'm saying that it shouldn't be your knee-jerk reaction when you hear an infant with recent antibiotic use has diarrhea. Keep this as part of your practice until around age 2 years, when infant microbiota matches adults. Any decision to send C. difficile testing in infants with prolonged diarrhea, anything beyond 10 to 14 days, should be made in conversation with a subspecialist. Okay, well, how about we send some IgG-based food sensitivity tests, just to be sure that the diarrhea isn't from the child experiencing sensitivities to all that table food? Well, our Choosing Wisely list and the evidence don't support this either, because these tests are unreliable and, again, nonspecific. Elevated IgG is a normal physiologic response to exposure, and food-specific IgG levels are found in healthy children with no digestive symptoms. This was confirmed in a double-blind, placebo-controlled study that attempted to correlate food allergy symptoms with IgG and IgG4 levels. So what? You want me to tell this family to go home without doing anything? Oh, no. I never said that we were going to do nothing. You know me. We're going to spend an extra few minutes in the room talking this family through their hesitancies with the rash and diarrhea and leave them with lots of connections for why we do what we do. We've already talked about management of the rash, and if you really think the diarrhea is related to food sensitivities, I recommend you monitor anthropomorphic measurements frequently and suggest a food diary to methodically assess for a correlation of symptoms. If the pattern suggests sensitivities, try an elimination diet to find the culprit. Otherwise, I think it's likely a mild, viral, self-limited infection that will resolve spontaneously in a few days. Offer the family anticipatory guidance of what to expect, how to resume a solid diet safely, discuss the replacement of ongoing losses, and how to assess for dehydration. And what does every family deserve before they leave? That's right, you can say it with me. Clear, objective return criteria. This includes blood in the stool, duration beyond 7 to 10 days, severe abdominal pain, lethargy, prolonged fever, dehydration, or drainage from the rash. Each of those is tied to a complication, sequelae, or alternative diagnosis that I'm considering, but reassured against right now. And when we share those items with the parents, they become part of the healthcare team at home and functionally expand your child's access to health, because health exists on a continuum, and you never know what will happen once they leave the encounter. And isn't that incredible that your partnership is changing outcomes without costing a single red penny? As you grow more experienced in having these conversations, you can also become more efficient in them because it's easier to predict the most common questions and curate a script that addresses concerns succinctly. And that takes time, but for now, you've saved this child exposure to multiple antimicrobials and invasive testing that might subject him to even more pointless interventions. You chose wisely to focus on what you knew the science tells us this child needs most. I hope you'll join us again next time when we follow a child with respiratory distress through multiple acute care settings and manage the case with thoughtful, choosing wisely based decisions that help us become better stewards of our resources while avoiding potentially harmful testing and treatments. Don't forget to like and follow the Peds NP, where we discuss the practical application of evidence-based practice in a conversational way that helps you synthesize and transform the best practices from the literature into your clinical bedside skills. Thanks to the acute care PNP faculty who reviewed this episode. And the Peds NP is built on grassroots foundations in communities of interest. So share it with a colleague, pass it along to your classmates, and text it to a friend. There are no relevant disclosures for this episode of the Peds NP. Follow me on Instagram at the Peds NP Podcast. Email me at thepedsnp@gmail.com. And remember, this isn't just a podcast. You're providing evidence-based reassurance and comfort for families. I'm Becky Carson. Take care.